Yeah, and Tony, we're doing molecular profiling in our metastatic patients. We think a lot about stage 2 needing to know MSI. I even think maybe we ought to know in stage 3, although I'm not sure what to do with it. What's your practice before making a treatment decision around MSI in the stage 2 and stage 3 patients?
I think every patient with colon cancer should get their MSI as part of and that's been done in most of our institutions. MSI has to be part of the program. It has two roles, right? One of the reasons we get it, the primary reasons we get it, is because it may lead us down the pathway of a Lynch syndrome. And identifying Lynch syndrome would be important for not just the patient, but their families, but it also affects how we follow up those patients, regardless of their risk. The second, it's a good prognostic element. That matters a lot in some ways because it doesn't change what you do. But the third, I think is important too, is it seems to negatively predicate for the efficacy of 5-FU, not for oxaliplatin plus a fluoropyrimidine, but for 5-FU alone. And that may sway essentially the decision-making process, especially in the stage 2, but also in the stage 3 when you're thinking perhaps about maintaining some of these patients on 5-FU after you're done with your 3 months of oxaliplatin.
Mike, I had this rash of patients, and one actually, doc called me to ask me, over 70-year-old, where in the stage 3 setting, where they found him to be MSI high, right, an acquired non-Lynch MSI high. And they're like, well, what should I give this patient? And I'm struggling between a watch and wait for all the reasons Tony just said. Oxaliplatin not really that helpful in the over 70 crowd, we can debate that a bit, versus giving them 5-FU-based, oxaliplatin-based therapy. What's your take on an over 70 stage 3 MSI? We're finding more of those.
Yeah, that's true. The current thinking is that stage 2 and stage 3 are biologically different, and the MSI seems to have a different impact in stage 2 and stage 3. And I treat the stage 3 patients with FOLFOX. I agree with you that the Accent database raised the question about benefits in older than 70, but I think most of us feel that has a lot to do with performance status and ability to tolerate the therapy, and less so that there's something magic about being older than 70 and not necessarily benefiting from the therapy.
I always think about this MSI high stage 2 means it hasn't spread, which maybe means that the immune system is actually recognizing, whereas in a stage 3 MSI high, it's somehow already escaped, right, because it's grown in the lymph node.
Well, right.
Is
when
there
you
any
think
rationale to that, or is that just my craziness?
No, I think there clearly is, and obviously when you get into stage 4, being MSI high does not confer a benefit to you prognostically.
So you've already demonstrated an escape from the immune system.
Yeah, presumably there's something that's keeping the immune system from recognizing all those neoantigens at that point.
Would you want to consider enrolling them in the MSI high trial though for stage 3 patients?
Indeed you would.
But so this is a struggle, right? So that's back to my initial question to Tony is, when do you test? When do you know? And a lot of times we don't know. Some of our pathology partners are going ahead and reflexively doing at least IHC on these. So we often have this right when we're making the decision, but sometimes we don't. And so do you wait?
Well, that's a tough one. Do you wait? Ideally, yes, but how long? Yeah. We're limited by time. Oftentimes we see these patients about 5 to 6 weeks, into their surgery. And then this is a quick test, but if their surgery was outside, then to get their tissue and all this, you may miss your window of opportunity. And we know we lose benefit beyond 8 weeks. Yeah. Ideally, yes, you should wait and have this as an element. In fact, ideally,
IHC might be you could do that fairly quickly.
Absolutely, as long as you have the tissue.
Yeah.
And so I think actually we have to really train all our pathologists to make sure, regardless of the setting, to have this as part. Same way you count the lymph nodes, same way you're looking at your Ts.
Same way they do ERPR on every breast cancer without thinking. We need to train our pathologists.
It shouldn't even be the thought.